Hi guys, welcome to the Blood Transfusion podcast. Anaesthetists commonly transfuse blood as a life-saving intervention, but there are a couple of pitfalls we need to be aware of. So how do we categorise blood and why can this cause problems? The cell walls of red blood cells can contain antigens and the serum can contain antibodies. If matching antigens and antibodies come into contact forming a complex, the whole circulatory system can seize up, which we as doctors would be responsible for by transfusing incompatible antigens or antibodies. We describe blood by which of the major antigens A and B it possesses. Group AB has both antigens, Group O has neither. If you have only antigen A floating around on your red cells, you cannot have antibody A in your serum because you'd be in a constant state of immune reaction. You will, however, probably have antibody B. So if I were to transfuse Group B blood into you, it would promote this massive immune cascade. It follows, therefore, if you're Jammy Dodger AB group, you can receive blood from anyone because you cannot have the antibodies. Conversely, anyone can receive O group blood, as it has no antigens present. This is why it's used in emergency situations where you don't have the time to fully cross-match blood. It's sometimes called flying squad blood for that reason. Blood has two headline jobs: transporting oxygen around the body, but also to clot itself and cause hemostasis. It's sometimes easier to think of it a bit like minestrone soup. You need the correct ratio of carrot to pasta to get a really great soup. If we stored donated blood without separating it into components, it would form a massive bag of jelly clot, essentially. Instead, we centrifuge it down so we can store each component separately, preventing it clotting, and also allowing us to be more targeted by giving the patient exactly what they specifically need rather than just total blood, full of clots. So thinking back to the two main jobs of blood, if someone's hemoglobin has become so low they cannot transport enough oxygen around, we give them red cells. Or if a wound or trauma is just bleeding, we can use lab tests to figure out if it's because their platelets are low, their clotting proteins are low found in fresh frozen plasma, or if the fibrin meshwork on which blood clots, found in cryoprecipitate, is low. Things can go wrong when transfusing blood, and there's stuff which can happen immediately or early on, and then there's stuff that can happen a bit later. Immune transfusion reactions happen when antigen-antibody complexes form, discussed earlier. This can potentially be fatal and would be entirely down to the healthcare professionals involved in the transfusion, so it's kind of a biggie to be aware of. Transfusion-related acute lung injury, or TRALI, is pretty rare but potentially serious. As with any fluid, you don't want to give too much too quickly, causing pulmonary edema. Blood is a brilliant medium for bacteria to grow in, and we can potentially cause a septicemia with this. Complications of massive transfusions are all about keeping the minestrone soup balanced, and we'll discuss this later. So what stuff can happen later? In terms of infectious diseases, we're mainly talking viruses here. And before screening, there were incidences of HIV or the hepatitises being transfused into people. Blood also contains a very high amount of iron, which is great if you're iron deficient, but if you're having transfusions over a period of a lifetime, for example, thalassemia, you can cause iron overload, and it deposits into tissues causing problems. Immunosuppression occurs because you're essentially transfusing non-self into a body, so the immune system becomes a little bit distracted from other things that it might be needing to deal with. Although we cross-match blood for the major AB groups, there are literally thousands of other minor antigens present in blood, which the immune system will develop antibodies to. This can make it harder and harder to cross-match someone in the future as they have more antibodies. What if something's not quite right whilst transfusing blood? Well, just stop it. There's no reason why you can't restart the transfusion later. Then check that you're giving the blood that you intended to give to the intended patient. Do a quick Dr. ABCDE and establish if actually you need some senior help at this point. Put a finger on the pulse, check the blood pressure, give the patient some oxygen, and do some baseline tests. If the patient is in circulatory collapse, they might need some adrenaline. Get the crash trolley, get the most senior nurse on the ward. Adrenaline is usually prepared in 1 milligram doses. If this is a small 1 ml ampule, this should be given IM. Don't throw the unit of blood away. The blood bank will want to do an investigation into what's gone wrong. Mild reactions are actually quite common, and most hospitals will have a guideline as to how to deal with these. Low-grade tachycardias or fevers often just require the speed of blood transfusion to be slowed slightly and may improve with paracetamol or some antihistamine. Transfusion reactions can be potentially life-threatening never events. No one will ever be angry with you for escalating sooner rather than later to your seniors. Occasionally in trauma or surgery we have to give huge volumes of blood in order to stabilise a patient. A massive transfusion is defined as 1.5 times a patient's blood volume or a total blood volume within 24 hours. Speed of bleeding in mils per minute is hard to quantify, but 150 mils per minute is used as a cutoff for a massive transfusion. Problems related to massive transfusions are because you're giving a larger number of units, you're probably giving it quite quickly, and the patient's in a pretty bad state to begin with. Minestrone soup that sat in the fridge for 2 weeks is going to be less tasty than that straight from the stove. The ability of blood to transport oxygen degrades with time as it loses an essential component, 2,3-diphosphoglycerate. The blood comes cold from the fridge, and you need to remember to add in the other ingredients of the minestrone soup, the platelets, the plasma, and the cryoprecipitate. The blood will be low in calcium, which is also essential for clotting, and as the red cells degrade, they'll release potassium and acid. So we need to give enough, but not too much, and make sure we're keeping things as normal as possible. And these are a list of parameters which it's sensible to keep the body within. A hemoglobin of 70 is often considered the adequate level for tissue perfusion, so there's no point aiming for 130. Cold and acidic blood clots very poorly, so we need to keep the patient warm with as normal a pH as possible. Blood needs adequate calcium and platelets for clotting. The PT or APTT are a reflection of the concentration of clotting proteins in the plasma, and when low need to be topped up with fresh frozen plasma. The fibrinogen concentration reflects the amount of fibrin mesh available to form clot on, so when low needs to be topped up with cryoprecipitate. Blood is a precious resource and not without risk, so we need to be responsible and minimise the amount that we need to give of it. Simple things to minimise blood loss, such as pressure and tourniquets, mean we have to transfuse less back in. And early attention to maintain coagulation can minimise the amount of blood lost also. Ensure your patient has enough clotting proteins, platelets and fibrin. In really serious bleeding, the trauma experts will give platelets and FFP for every single unit of blood red cells they transfuse. Most hospitals have a standard issue major hemorrhage pack, which will deliver platelets and FFP alongside your red cells as a reminder. What alternatives are there? Well, blood is pretty epic, so let's make sure we lose less of it. Keep blood pressure adequate, but not so high that it dissolves clot, and minimise bleeding whenever possible. Autologous blood transfusion can occur for anticipated bleeding, for example, major surgery. A patient will donate their own blood for storage to be transfused later during their planned operation. Cell salvage is a fancy gadget where a patient's own blood is collected during surgery, medically washed, and then transfused back into the patient shortly after. Erythropoietin is a hormone produced by the kidneys which promotes blood production in bone marrow. Injections of erythropoietin, or EPO, can take weeks to work, however. Purified and recombinant hemoglobin aren't available in clinical practice yet, but may well be the future of blood transfusion. A lot of time and money is being put into finding an alternative to carry oxygen, for example the perfluorocarbons, but again are not available in clinical practice yet. But watch this very exciting space. Thanks for listening, guys. I've been Viv Hannon, anaesthetic registrar.